the understanding of fluid resuscitation, especially in relative hypovolemia, in sepsis, has changed a lot. The classical Starling's theory, which we were taught in our medical colleges and even now in most of the physiology textbook, looks at the fact that the blood circulation comes out from the capillary, arterial end of the capillary and joins back at the venous end, with filtration happening, and the filtration then depends on the difference in oncotic pressure and hydrostatic pressure. But this theory is very simplistic, and this doesn't explain the effects that we would explain, and because of this we would expect that crystalloids and albumin and this thing will be a 1:4 ratio. That means colloids will have 4 times more vascular expansive property than colloids and then crystalloids, and this doesn't happen. What we see is why it doesn't happen. Nowadays the ratio is 1:1.4. So why it doesn't happen is because of this modified, what we call as a revised Starling principle. And what is happening here, you can see in the first and the second slide here. So here you see is an intact glycocalyx, and here you see is a damaged glycocalyx. As a result of what you're damaging, what you're seeing is that the filtration is affected, and the amount of fluid that goes out is not only determined by the oncotic pressure and the hydrostatic pressure, but the main determinant of the hydrostatic pressures have been the glycocalyx. So once you lose that, all these plasma proteins are going to not be able to come in back into the, as we are expecting, but is going to create a different issue. So what we are trying to say with this different physiological basis from the revised Starling principle is that the blood is returned from the arterial end to from the capillary to the venous end, not in the simplistic way, but it goes back through the lymphatics, and the fluid diffusing out from the capillary into the interstitium and then into the cell is not only a determinant by the hydrostatic pressure and the oncotic pressure, but it is determined by the state of your glycocalyx. That means this damage to glycocalyx, as we see this damage happening in, say, any endothelitis or any sepsis, is what will determine how leaky you are and how much fluids you will require to do it, and then the side effects of fluid will happen because of these things. So this is an important concept that we need you to be aware of, that the reason the modern physiological basis for fluid resuscitation and therefore the volumes required and therefore the volumes of crystalloid and colloids are slightly different as it is required. So it is no longer that the colloids are going to be 4 times more effective. It's only going to be about a fraction more effective than crystalloids, is what the data is telling us. All right. So now moving on to the physiochemistry of the various fluids. By definition, crystalloids are those which are basically crystallizable. They include salt, sugar, urea, while colloids are derived from the Greek word glue, and so on and so forth. That's the traditional way in which but now we basically define them as commonly solutions of ions that are capable of passing through a semipermeable. That's what a crystalloid is. So with the exception of pure glucose, everything else is crystalloids contain sodium, chloride and other anions, which will determine your tonicity and which will determine how much fluid was the physiochemical properties. And crystalloids can be used as resuscitation fluids, or can be used as maintenance fluid, or can be used for replacement fluid. So crystalloids have a wide variety of uses that we are talking about. These are the non-normal saline crystalloids, which we call as Hartmann's solution or sodium lactate, Ringer's lactate, Ringer's acetate, plasma light 148 and plasma light A. So all of them we need to understand what their osmolarity is. All of them are slightly hypoosmolar because the normal osmolarity, serum osmolarity is between 288 and 294. So they're slightly hypoosmolar, but the chloride and the chloride content is much less as compared to the normal saline, which is what we use commonly. So normal saline, or a lot of people, have to remember that the sodium content is 154 and the chloride is 154, while the plasma chloride is normally about 100. So you got a significant high amount of hyperchloremia, and this amount of high volume can lead to hyperchloremic metabolic acidosis. The high chloride load can lead to AKI, but still it is the fluid of choice for a few situations. One of them, it is a first line resuscitation for hypovolemic owing to upper GI fluid losses. And it is a fluid of choice in patients with acute traumatic brain injury. So it still has role both as a resuscitation fluids and for treatment of fluid of choice for TBI. So this is, despite the bad name because it has acquired because of the hyperchloremia, it still is a good fluid to use in certain situations, and those are the situations that I just mentioned to you. But what we are now seeing is a buffered salt solution, where basically you are trying to make sure that the chloride is not high and it's in the physiological range. And you would like ideally to add bicarbonate, because that's what is the normal when we do a basic metabolic profile. But bicarb is unstable in a plastic bottle, so we put acetates, lactates, and so on and so forth. So these are the buffered salt solutions, which we just showed you in the previous slides, the Hartmann's, Ringer's, Plasma-Lyte, and the newer ones, Plasma-Lyte 148 and Plasma-Lyte 8. So these are the crystalloids which are not normal saline, or which are what is called as buffered salt solution. Moving on to colloids, as I said, they are the ones that semi-synthetic molecules that cannot pass through intact semi-permeable membrane. So we expect that they will remain in the intravascular space much more than what crystalloids will do, and that was the reason for it. And as I said, the intravascular volume expansion that you can achieve by plasma derivative 4 to 6 hours is much longer than produced by semi-synthetic colloids, 1 to 4 hours, although actual durations will vary substantially, and the amount that is going to be in the solution is also going to be significantly diluted. The theoretical advantage of colloids is that this has always been the theory that you're going to require a reduced fluid volume to produce the same hemodynamic effect. And the standard 3:1 rule or 4:1 rule, as I said, because of the modified glycocalyx and the modern Starling's theory, we now know is no longer that, and it is 1:1.4 is what is the efficacy rate as far as colloids are concerned. So the colloids as a resuscitation fluid are useful, but the effect has always been overstated, and we need to now come down and say this is not how important the effect is. The albumin that is available in the Western world is a 4%. We have a 5% and a 20% albumin available, and this is what we use. Obviously, these are contraindicated in acute traumatic brain injury, but they are recommended in patients with sepsis who are not being stabilized with crystalloids. The SAFE study has shown that these are safe, especially in sepsis. And when necessary, you can use any of these as a volume sparing agent. But even now, we will talk about what is the fluid of choice. So this is the SAFE trial that I was mentioning, saline versus albumin. They use 4% albumin, which is available in New Zealand and Australia. They didn't find much of a difference, but in sepsis, there might be a trend towards benefit with the use of albumin in sepsis. In the Albios trial, which is the Italian outcome study in sepsis, again, if you add less than 3 grams of albumin, which is what most of our patients in India had, give them albumin and see if it makes a difference. Again, no difference in, no between group differences in patients with mortality or any other this thing that proves that albumin is superior to crystalloid or in treatment of the resuscitation of patients with low albumin and sepsis. All right, so what we now next come to is the fact that if you are giving fluid, resuscitating without any endpoint, you're going to end up with what is called as a fluid overload. That means your fluid balance, and especially if it's more than 10% as shown here, so this is going to lead to a poor outcome. So we really don't want to have a cumulative fluid balance. That means if you put on 10% of your body weight, you're going to die is much more very certain, especially in this thing. So you'll become like this Michelin tire man. You will have consequences on the respiratory system, the liver, the GI system, abdominal walls, CNS, cardiovascular, and renal systems. I'm not going to list all of this. This is just illustrative to tell you that large volume fluid resuscitation without having an indication, without having a goal, can have disastrous consequences. So fluids cannot be taken lightly when we give them fluid therapy. All right. So what is the present concept of how do we resuscitate patients? There are two main theories. One is called the SOSD and the other is called as the ROSE therapy. Go back and we'll discuss what is the SOSD, which is what a lot of people use, and ROSE is also used equally. So ROSE, SOSD stands for, S is for salvage. So whenever we want to salvage somebody, that means you come in with acute circulatory failure and you don't have a really good blood pressure. You want to immediately do an assessment with an echo or with other hemodynamic tools, and you give crystalloid aliquots of 0.5 liter or 5% albumin or 4% albumin if you have sepsis, and start inotropes or vasopressin.